Hey everybody. We're going to start wrapping up our video notes for Unit 12 with the disorders, starting with this neurodevelopmental content, the disruptive disorders, and then the somatic symptom disorders. And then we'll touch on schizophrenia, which will be your last one, and that'll be a separate video. Partially just because this one's a doozy. There's a lot that connects in with these various different diagnostic categories, and each one of them has multiple different disorders within them. So, like I've shared with you on numerous other occasions, this will be a little overwhelming in the video because I'm having to cover it fairly quickly with you guys. But we are definitely going to try to make sure that we do enough in class with you via case studies and things along those lines to be able to differentiate between all of these symptoms that seem to sound very similar to one another. So we're going to tackle neurodevelopmental disorders first. They used to be called developmental disorders before the DSM-5 revision, and so now they're called neurodevelopmental. But this is going to involve distortions in an individual's ability to develop normally with regard to social skills, with language, perceptory processes, or even motor skills and functioning. Okay? Most neurodevelopmental disorders are going to get diagnosed in infancy, childhood, or adolescence, for example. We just went to Eliza's 18-month doctor's appointment right before I have videotaped this discussion and this conversation that we're going to be having on this. And we had to fill out a pretty extensive questionnaire with regard to her different capacities and functionings. Whether they be her social skills, some of her motor functioning, language, things along those lines, to be able to, if there were questions or concerns, to have early intervention to address whatever possible neurodevelopmental issues she happened to have. Now, I'm going to be very straightforward with you. This is super overwhelming to look at this slide and see all of these different types of disorders. You're not necessarily going to need to know all of these. I'm going to spend the majority of this video talking about autism spectrum disorder and ADHD, okay? But because it's possible that some of this stuff could show up for the AP test, or because I know an awful lot of people can identify with these or understand what these things are, I'm going to talk about a couple of different pieces very quickly other than ASD and then ADHD. Okay, so intellectual disability, remember from our Unit 11 content, it used to be called mental retardation. It is no longer that. Okay, this is an individual whose cognitive functioning is, in terms of that intelligence piece, is below the ability to be able to function normally and particularly on their own without any level of help. Okay, communication disorders would be things like stuttering, okay, or a lisp. Those would be examples of specific communications disorders. I'm going to skip over to motor disorders to talk about like Tourette's or other different kinds of tic disorders. And then you have specific learning disorders. Those are no longer individually identified, so you don't have things like dyslexia or dyscalculia, which is like inability to solve math problems and stuff, interchanging numbers and signs and stuff like that. They're no longer really categorized like that. They're simply just called now specific learning disorders. So I would know that just for a general sense because they might try to throw those at you as distractors on the AP test, excuse me. But for our purposes, I'm not going to spend a lot of time focusing on them because they're just not as significantly assessed. Okay, so let's talk autism. It is now known as autism spectrum disorder. The old diagnosis of Asperger's syndrome has now been combined and added into this, and so it is all now just one categorization of autism spectrum disorder. It's typically going to present as unusual patterns of both social and cognitive development present in childhood, and so you'll see it presenting as difficulty with regard to social interactions and communication. It is very common for you to see autism present itself before the age of 3. Typically, it will present much earlier. So one of the things that we did for Eliza at her 18-month appointment was to check off on certain things with regard to her social interactions and her ability to communicate. Because we have found through research that if autism spectrum disorder is caught or identified fairly early on, steps can be made via treatment, whatever that treatment happens to be decided upon, to help that child be able to develop exponentially more normally. It is far more common to see autism spectrum disorder identified in males than females, 4 to 5 times more likely to be specific, which is a pretty staggeringly high number. And there's also something to keep in mind for yourself, that about 70% of those with autism spectrum disorder also have an intellectual disability. It's also possible to see a multi-diagnosis, or what we call a co-modality or a dual modality, depending. Dual means two. So it's possible for somebody to be diagnosed with 2 disorders within this, both autism spectrum and also obsessive compulsive disorder. You'll understand what I'm talking about with that in a second when I start listing out some of the symptoms. Co-modality is that there's multiple levels. That would be something along the lines of an anxiety disorder. It's very common for people to be both agoraphobic, be diagnosed with panic disorder, and have generalized anxiety. Okay, so that would be, obviously more than 2 scenarios of a diagnosis. So about 70% of those within autism spectrum disorders have an intellectual disability as well. How do you identify behaviors or symptomology within ASD? It's very much going to revolve around the social interactions and the expectations of how a person should be able to behave in social interaction and in their communication in general. Okay, so there are going to be pretty significant deficits in that. They're not able to do things in terms of normal back and forth conversations with one another, or initiate or respond in an appropriate way to social situations. Okay, they struggle with an awful lot regarding nonverbal communications. They don't necessarily have the ability to make eye contact with you when they talk. That's not something that they can do very easily. They don't have a lot of emotional expression and facial expressions when interacting or talking with another individual. They don't understand certain aspects of social cues. They'll interrupt you or interject when you're attempting to talk, because they just don't understand that, it's a social norm that one waits until an individual is finished speaking before they interrupt or interject their opinion. They have difficulty being able to adjust their behavior to suit a situation or the context. So they don't recognize that there are some times when it's okay for you to, for example, share a brutally blunt, honest opinion, and others when it might be not so good for you to do that. Like, say, when a peer is sharing a personal story about, a family member or a loved one who has passed away. Someone with autism along the spectrum is not going to understand that maybe it wouldn't be a really good thing for them to respond in a very blunt or kind of tactless way. They also struggle with imaginative play, which is another one of those key diagnosing components when a child is very, very, very young. They don't know how to be able to interact with peers or the imaginative play component, because it's just not there for them. There's a lack of interest in it, and so they don't demonstrate those behaviors as a result. You also have a categorization of restrictive repetitive patterns, and this is ultimately why you heard me say that it's possible for someone with ASD to be diagnosed with OCD as well. That was the case with my cousin. He had very obsessive compulsive tendencies, and he is also autistic. So they need very much a repetition and constant level of predictability to their routine. They're very inflexible when that routine gets altered. They don't know how to respond to it. They do not respond very well to it at all. They need that ritualization component. Okay, so they need to, for example, take the same route to school every day, eat the same foods every day, respond, have the same beginning to their morning every single day. There's also possible repetitive motor movements that can be present. They have to line up toys in the exact same way, or they will carry out, they have to repeat the same phrase and have some, levels of idiosyncrasies to that extent too. They can have very strong attachments and preoccupations with things that are quite unusual and outside of the norm. This is very much where you would see Howard Gardner's assessment of savant syndrome presenting itself. He studied an awful lot of autistic individuals. And they can have very high levels of sensitivity to sensory input. They can either be just completely unaffected by large amounts of noise and things like that, or they can be highly stressed out by that. It can be very overwhelming for them and they just can't handle it. So that's what we're referencing here when we have that hyper, which is overreactivity, or hypo, which is the underreactivity as well. When we're talking about this component of, that impairment in social relationships, this is just further demonstration of those pieces. They're not very good at physical contact. They don't tend to like to be touched or held. In addition to that, avoiding of eye contact. There can be presentation of impaired speech. About half of autistic kids don't develop normal speech patterns when they're young, and that's a very key identifying factor in diagnosing ASD at a young age. If a child does not have a certain level of words that they have met by certain developmental points, that is a diagnosable characteristic of autism spectrum disorder. Speech is going to present itself in terms of like an echo of what is heard, not rather, a cognitive cycle of response back to you where you can tell I'm taking in what you're saying and I'm thinking through it and I'm responding in kind. There, as I said, very narrow range of interests and activities. Sameness and routine is very, 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 very important. They can become very distraught and angry, and possibly even demonstrate physical presentations of that. If things don't categorize along the lines of what they expect for that routine, they can demonstrate violence towards themselves. They can hit, for example. They can do damage to themselves. It's possible that they could do it to others, although it's not very common that that's going to happen. But it is something that is present there, and ultimately we do believe that goes back to a lack of ability to have selective attention that very much presents itself in autism spectrum disorder. What causes it? There is so much that is still trying to be looked at and researched when it comes to autism spectrum disorder, because we just don't know what causes it truly. There's a lot that's come out in pop culture in recent years with regard to vaccines and things along those lines. There's no scientific evidence that causes autism spectrum disorder, but it hasn't stopped an awful lot of people from perceiving it and believing it. So ultimately, what we boil it down to is that it's a combination of genetics and environment. There has been some research that's been able to identify quite a few number of genes that are associated with causing the autistic behaviors that present themselves. And there's also some research that shows that there are irregularities in regions of the brain, along with abnormal levels of serotonin and other neurotransmitters. So that would lend itself towards very much a biological component for things as well. But ultimately, it's important to recognize too that there are sociocultural factors too. Just because a child demonstrates some abnormal development, keep in mind what we talked about with the development unit. Some kids just develop at a slower pace. That doesn't necessarily mean that they have autism spectrum disorder, and some people just aren't as good at picking up on social cues. And in a day and age where we have a mentality out there of right or wrong, no judgment, political correctness, where we take certain things into account with regard to how another individual would respond based off of our verbiage and things like that, that can also play a role as well. Let's talk ADHD, okay? So this is when a person has very short attention span, easy distractibility, high distractibility, and extreme difficulty being able to maintain an inactive aspect of lifestyle for any kind of period. This is a very high percentage of individuals within the school age range. You can see anywhere from 3 to 5% of people that have been diagnosed with ADHD. It's possible to see multiple different subtypes of it. You can be predominantly hyperactive and impulsive. You could be predominantly inattentive, or you could be a combination of both of these. So let's talk about each one of these presentations in a person with ADHD. Let's start with inattention first, okay? They are highly easily distracted. They miss details, they forget things, and they're frequently going to switch from one thing to the other, okay? So it's very difficult for them to provide high levels of details. Their responses, for example, are going to be very brief and very simplistic. They can't just focus on one thing. It's very difficult for them to ultimately end up completing tasks then because of that. They become bored because of the easy distractibility, and so after a few minutes, they're going to move on to something else. They have difficulty being able to pay attention on organization and completing tasks fully through. So A lot of times it's not just an issue of starting a task, but it's completing it. So you'll see an awful lot of work from those with ADHD that ends up being just partially finished, or a quarter finished, or a third finished, not all the way. And they struggle with being able to organize, again, because that's just a task that requires a decent amount of focus, and for many of them that's just not there. And they can have trouble completing an awful lot of stuff then because they lose it. So they forget to turn things in, or forget that they didn't fully complete a task before, and then due date falls upon them and they're sitting there like, oh man, I totally forgot that was there. Some other demonstrations of inattention is that they don't always listen to you when you're being, when you're speaking to them. They don't have the ability to stay focused on the conversation at hand. They daydream a lot. They can become very easily confused by what's going on around them because of that kind of spacey behavior. They have difficulty processing information as quickly as you and I would, because ultimately there's so much other stuff happening up here that distracts them and prevents them from being able to, to narrow that focus and follow directions accordingly as well. Let's talk about the hyperactivity component. This is when you see like the pen tapping, the foot tapping. They fidget and they squirm an awful lot, particularly in their seats. They just can't stop talking. Okay, they're people who are going to start trying to have conversations with the individual next to them, regardless of what is going on around them in the environment. They're going to touch things or play with things. They will get up out of their desks for no reason whatsoever. I have quite a few of students actually that do that. They'll just stand up and get up when they're supposed to be doing seat work, and they'll walk up to my desk and they'll ask me the most random question of all time. And it's just because they have trouble sitting still, along with that inattentive component. They have to just constantly be in motion and constantly be moving. And so they don't do well when things involve quietness in that regard. And they do demonstrate some impulsivity. They just don't have the patience for certain things because of their disorder. They'll blurt things out at inappropriate times. They show their emotions without any level of restraint, which in and of itself isn't a bad thing. And they don't think about the consequences of their behavior. They just can't plan that stuff out and think things through, because ultimately they've got a pretty significant difficulty in waiting for things that they want, or waiting for situations to play out because of that impatience. They just want it to be done and get it situated. So if they're gonna, because of that whole thing, they're gonna interrupt you based off of the conversation that they're having, or your activities, because of that whole level of impatience, and ultimately the hyperactivity component as well. What causes ADHD? We do have research that shows that it's a combination of both genetic and environmental pieces. It can run in families. We do know that there are biological components to it, different brain structures that are connected with this. For example, those with ADHD often can have other disorders, whether it be learning disabilities, like what we talked about earlier. Sorry, that's my radiator turned on, like dyslexia, for example. They can be diagnosed with obstinate defiant disorder. It's not uncommon for you to see ADHD and other anxiety disorders present. GAD and its symptomology is very similar to what you see in people of ADHD behaviors. They can even have depression or bipolar disorder. It's important to recognize, though, with scenarios of these, comodalities happening, one disorder doesn't cause the other, but those disorders can make some of the symptoms of ADHD way more noticeable or severe, okay? And so because we know that there can be some biological components to this, treatment's going to involve an awful lot, more often than not, stimulants. Things like Ritalin, Adderall, Concerta, these are all very commonly prescribed treatments for ADHD. They improve the symptoms by having a calming effect, which seems very counterintuitive to people. Why would you give a stimulant to somebody who is hyperactive and already highly stimulated? Ultimately, though, what it does is it seems to have a calming effect based off of how it ends up impacting the brain. That's not to say that it's not going to have adverse side effects. Because it's a stimulant, for example, it's going to suppress appetite. So it's very common for you to see people who are on ADHD meds who don't ever seem to feel hungry. So in a lot of respects, they end up being fairly skinny because they don't have a desire to eat. Or it can make them feel sick to their stomach sometimes, so then they just don't eat because of that too. All right, let's switch gears. We're going to move into another category, which is disruptive disorders. They're also known as conduct disorders, okay? These are categorized by conditions that involve a person having pretty significant problems with being able to control their emotions, and that particularly connects to violations of social norms, inability to follow authority figures, or to recognize the rights of others. So you've got 4 types. This is intermittent explosive disorder. You've heard me make reference to. You're not really going to need to know that for purposes of the exam. I would know it in the sense that it is another type of disruptive disorder, but they're probably just going to throw that at you as a distractor. I would familiarize yourself, though, with the 3 disorders that I'm going to spend some more time focusing on right now, which are oppositional defiant disorder, conduct disorder. Well, okay, so 2. And then there's also pyromania, which is being a little bit too preoccupied with fire, and kleptomania, which is being compelled to steal an awful lot of stuff. So the 2 that I'm going to focus on are going to be oppositional defiant and conduct disorder. Okay, but for furthering purposes of understanding these, intermittent explosive disorder and pyromania and kleptomania are ones you might want to just keep in mind in the recesses here. So let's talk oppositional defiant disorder. You're going to see this typically start by age 8. Okay, but it has the possibility of starting as early as preschool years, where a child is for at least 6 months actively refusing to follow an adult's requests. They have anger and resentment toward adults and others as well. It's not just adults. They just have an awful lot of deep-seated resentment towards others. They're going to be argumentative with adults and with other people. They blame others for their mistakes. So, if a person with ODD, for example, were in class with me and they got a poor grade because they made a mistake on something that looks pretty obvious to you or I, their response would be, well, this is entirely Miss Ogle's fault. She didn't do what was needed for me to be able to be successful there. They have very few friends, if possibly any friends at all, because of this, highly argumentative and oppositional behavior. They're constantly in trouble, lose their temper very frequently, and a lot of the reason why they lose friends, too, is very spiteful and vengeful behaviors that they have toward other individuals. A very simplistic way of looking at it is they are just very touchy people who get very easily annoyed as well. The pattern of behaviors that present in oppositional defiant disorder have to be different from those of other kids around the same age and development level. Okay, and so ultimately that's why some of these disruptive disorders we end up covering when we're covering developmental disorders too, because they can kind of correspond with one another or piggyback off of one another. We do believe that there is kind of a biopsychosocial approach to explaining why oppositional defiant disorder presents itself. There can be biological predispositions that cause the higher level of aggression or anger or inability to respond well to authority. There can be psychological factors, the sense of, an authority figure is attempting to control me or lord over me, and I'm going to show them style circumstance, and then ultimately social factors. You see an awful lot of oppositional defiant disorder in childhood and in teen years, because the reality is, in many respects, you guys perceive that you should be oppositional to authority. It's kind of, an expected thing that teens do, to kind of thumb their noses at authority and parents and teachers and things along those lines. All right, let's switch gears to conduct disorder. You've heard me make reference to this before, because this is, in many respects, the predecessor to APD. It's antisocial personality disorder. Conduct disorder has been associated with issues of child abuse, family conflict, neglect, poverty, parental drug addiction, and just family conflict in general. The diagnosis is far more common in boys than it is in girls, and kids with conduct disorder are highly impulsive, incredibly difficult to keep under control, and they just don't have a level of concern for the feelings of other people around them. Okay, and so their symptomology is highly antisocial behaviors. They're bullies, they fight a lot, they break rules, and they just don't care about the rules because they don't feel that they apply to them. They can demonstrate fairly cruel and aggressive behaviors in the sense that they will look at animals as lesser, and so they will do just terrible things to animals. They'll mutilate them, abuse them, things along those lines. Destruction of property is fairly common in conduct disorder as well. They're going to deliberately do things like stealing your stuff, destroying other people's property because they just don't care what they're doing to you. They will do an awful lot of risk-taking behaviors that go in opposition to societal norms, like drug use. They lie to get what they want. Very manipulative style behaviors. So, I mean, you can see from these behaviors, they're very, very, very similar to antisocial personality disorder. So it's not a big leap to recognize that kids with conduct disorder can go on to be diagnosed with APD later on when they're 18 years old. Because if their behaviors do worsen, they can develop an awful lot of issues with regard to APD, along with legal issues and struggles with drugs as well. All right. Let's switch gears, try to wrap all this stuff up, start talking about somatic symptom disorders, okay? These are kind of difficult for kids to follow because ultimately somatic symptom disorders involve difficulty because you can't really ascribe a cause to what you're seeing via the disordered behavior, okay? So there's physical symptoms that present themselves to suggest a physical disorder, but there's no physical cause. In some respects, there's no psychological cause, although it's possible that there can be a psychological cause, or evidence to show that there's any kind of psychological factor, okay? So what you would want to familiarize yourself with is that somatic symptom disorder can be in and of itself an actual diagnosable disorder, but then other categories of it could be conversion disorder, illness anxiety disorder, which used to be called hypochondriasis, and then factitious disorder. So, let's bump on. I don't know why that keeps popping up there. So let's talk conversion disorder, all right? This is going to be where you have unexplained symptoms of a physical nature with no known physical or medical cause, all right? So often what you're going to see with conversion disorder presenting itself would be a person who suddenly goes blind. There is no physical reason why they cannot see, okay? You would think that blindness would have a medical condition attached to it. There's something going on with the eyes, something going on with the visual cortex, for example, or the occipital lobe, okay? There's no medical reason that can be found for why the disorder is presenting itself. Here's the thing. Usually, the onset is after a stressful event, okay? So there is some kind of like psychological connection to it, but it's important to recognize that with conversion disorder, most of the symptoms are anatomically not possible. Okay, so like paralysis, for example, or deafness, just suddenly going deaf, and there not being a physiological cause. There's one type of symptom of conversion disorder out there called glove anesthesia, where you can't feel your hand, but the person still has sensation in the arm, the nerves still function. So it's a very strange disorder to a lot of my students. They just can't wrap their brains around it. There's one example that I can give to you that if you've ever seen it, will kind of connect for you to recognize it as a conversion disorder. You often can see conversion disorder present itself in individuals who've gone through war. For example, there is a video I'm going to show to you guys in class of a guy who develops conversion disorder right after the D-Day invasion happens. He was part of the D-Day landing, and he goes blind. He just can't see, and there is no physical reason. He was not injured. He did not get shot or anything along those lines. The stress of that event evoked that scenario from him, okay? Another one would be paralysis. If you've ever seen the Sherlock Holmes version that has Benedict Cumberbatch and, I'm blanking on his name, but it's the newer updated BBC version of it. It's available on Netflix. John Watson, that character in the first episode, has conversion disorder. He walks with a cane and perceives himself as having a limp in his leg due to a resolved injury he experienced when he was in Afghanistan. But he still feels the pain, and he still perceives as if he cannot move that leg and needs the cane to be able to walk. He's showing a conversion disorder in that circumstance. One of the most significant indicators of conversion disorder developing is that a person has that extreme anxiety that we kind of talked about, that stress, in another area of their life, okay? But here's the thing, there's a lack of concern about what appears to be some kind of physical ailment that is incapacitating them at that point in time, okay? So ultimately what's presenting itself there is it allows a person to escape from that stress by leading to what is called a secondary gain, such as attention, affection, things along those lines. So if you looked at the scenario of the guy in Band of Brothers who goes blind, well, if he goes blind, he can't participate in any other attempt of that war to fight the Nazis. Okay, so that would kind of help him circumvent around that stressful event or life circumstance. So that would be something that would connect in with conversion disorder. Let's talk illness anxiety, formerly known as hypochondriasis, someone being a hypochondriac. I'm going to pull this down here. There's nowhere for me to really ignore this stuff, so I'm just going to pop it back up here. So with illness anxiety disorder, this is when a person is overly concerned with bodily events and perceiving them as exponentially more serious than they actually are. So, for example, somebody with illness anxiety disorder would get a headache, and they would ultimately jump, major leap to thinking that that headache is a signifier that they have a brain tumor and they're going to die. So there are three major characteristics, excuse me, I'm stumbling over my words, that connect in with illness anxiety disorder. Okay, you've got the physiological arousal, the worry or the anxiety that connects in with that. There could be sleep disturbances and things, for example. The bodily focus, so they are constantly monitoring symptoms that could present themselves in physical ailments. Okay, so you've got a cough, that's going to mean you're instantaneously going to develop pneumonia, for example. Okay, and then you've got the behaviors themselves that are designed to either check a physical illness, make sure that it is not a bad thing, or avoid it. Okay, so they're trying to avoid those who might have a disease that they perceive a fear of developing, or constantly looking over things, self-inspecting, looking at medical consultations. It's a little bit of a morbid joke, but it's one that certainly could be identifiable to this, that WebMD has ultimately contributed to an awful lot of illness anxiety, because, I mean, truly, if you were to Google headaches, in terms of, stuff that can pop up for you as symptoms, an underlying cause could be a brain tumor, a brain bleed, the possibility of a stroke, and it's just all of these awful things that could happen. Sometimes headaches are just headaches. There's not necessarily something that leads to a really super serious cause for it. All right, let's start rounding this stuff out with factitious disorder. This is when a person acts as if they have an illness, but they don't, okay? And so they go about attempting to consciously create symptoms and have them treated. They're going to exaggerate things that are present in them in terms of an illness. They might lie about symptoms that they are presenting in themselves. They might try to hurt themselves to bring on symptoms. May try to, for example, alter diagnostic tests, like contaminating a urine sample so it will test positive for some kind of issue. So when you've seen, for example, situations on the news where you hear people who went around, for example, saying that they had cancer, and people created GoFundMe accounts and did all of these things to raise money for them, and it turns out, nope, they don't have cancer. It's entirely possible those individuals could have a factitious disorder because they are trying to kind of drum up this effort to receive attention by having, this disorder that, or, this disease that they don't actually have. Okay, they have an inner need to be seen as ill or injured. Okay, there isn't going to be like a financial gain in every circumstance. More often than not, that's not the case. In some circumstances, like Munchausen's or Munchausen's by proxy, it's a need to be wanted or to have a sense of attention aimed at them. Munchausen's by proxy, you've heard in many respects, if you're a fan of Eminem, he's accused his mother of that, where a parent will purposely make their child ill so that way ultimately there's an awful lot of attention that gets aimed at them, not only to be a caretaker and a provider to that kid, but ultimately then a whole bunch of other people are kind of focusing on it, like, oh my gosh, you poor you, your poor child, things along those lines. So it's possible for there to be Munchausen syndrome where it's you creating the physical symptoms for yourself. It's also possible for there to be Munchausen syndrome by proxy, which is like a proxy is like another individual. So you make someone else physically ill in your care. And so that's another type of presentation of a factitious disorder. But ultimately, the key defining piece here is there isn't actually something there. They are exaggerating symptomologies or the presence of things because of some psychological reason rather than a physiological one. So this was a mouthful. This was a lot of different disorders to throw at you in 35 minutes. We will do our very best to make sure that you can differentiate between these guys in class with different activities. As always, let me know if you got any questions.